Okay. Hello, everybody. This is Dr. Marston for class number 4. And then this week we will be talking about, today is January 28th. I just want to make sure I'm on the right set here. And we are going to talk about competence and human relations. Competence, let me start with competence and I'll go through. My plan is now that we are um, in the area of the course, where each week we will talk about at least one, but I believe in most weeks at least two specific ethical principles. So this week we will be talking about um, competence. And my plan is as we go through each of these different um, ethical principles, what I will do is kind of go through each of the specific um, ethical standards and maybe even through each section. In fact, my plan is to go through each section of each standard and sort of give a little bit more detail, a little bit more flavor to your understanding of what um, these different ethical principles are talking about. So let's start with talking about competence. It's an interesting thing to consider what competence means. Um, when you are training to be a psychologist, you are needing to show your competence in understanding clinical psychology. I believe all of you have said that your plan is to take the licensing exam in your state. So that would mean the licensing exam is by definition there as a way for you to show your competence in understanding clinical and or counseling psychology. In most states, it's interesting to keep in mind that the American Psychological Association, for instance, distinguishes between clinical psychology and counseling psychology, but the licensing boards of almost every state do not. They do not recognize a distinction. So, for instance, in the state, you are licensed as a psychologist, not specifically as a clinical psychologist or a counseling um, psychologist. That makes it easier to identify um, competence for a licensed psychologist because the licensing boards aren't needing to distinguish between what is a counseling psychologist and what is a clinical psychologist, or for that matter, what an organizational psychologist is. Um, so for the most part, when you get licensed, you will get licensed as a psychologist. But the general thinking is that just shows a minimum of understanding of what you need to have in order to practice as a psychologist. So, in many different types of situations, you will have to show or be able to show that you have competence in the field where you're working. Probably the one that pops out the most is working with children. Not every psychologist has the competence to work with children because working with children is not the same as working with adults. So if you have only had training clinically in working with adults, you would not be able to ethically say that you can work with children. If you are wanting to work with children, you would need to be able to show some evidence that you have competence in that area. Um, now, there are probably one of the reasons this can get sort of dicey. Actually, there are a number of reasons how this can get sort of dicey and unclear. One of it is that if you take the licensing exam in most states, there will be questions about children and child psychology and developmental psychology on the licensing exam. And if you've taken a degree in clinical psychology, most universities would require some sort of developmental or child psychology course. So the question then becomes, um, is that sufficient for showing competence in working with children? The general answer to that is no. That just because you can answer the questions on child psychology or developmental psychology as they exist on the licensing exam, the understanding is that is not sufficient for saying you can then go practice with children. You can then, extend your practice to working with children. Generally, the expectation is that if you're going to work with children, you have to have had some supervised clinical experience working with children. In other words, as a licensed psychologist, your first time working with children should not be you working entirely by yourself. So even licensed psychologists are expected to um, get some sort of supervision if they want to switch from um, uh, working with adults only to working with children. So the question of competence when it comes to working with children typically comes down to, um, do you have some sort of supervised clinical experience working with children? And it's usually expected that because working with children is so different than working with adults, the understanding is that you should have had some experience where there is a supervisor who is sort of looking over your shoulder, not literally, but in some way looking over your shoulder, meaning they are checking your work, checking in with you to sort of review what you do. So the bottom line is a psychologist who has passed his licensing exam but does not have supervised experience working with children, that psychologist would be expected to obtain some sort of supervised experience working with children or have a consultant available to them if they are working with children. So that's an example of how the issue of competence comes in. Now, what then becomes a legitimate question is, where does the issue of competence come in terms of when you are licensed as a psychologist, what is the boundary in terms of, well, being licensed as a psychologist means you can work with this group, and this group, but not this group without supervised experience? Does it mean you can only work with adults with depression if most of your clinical training was working with adults with depression? So the issue of competence comes up um, in a number of different areas. Now, I will tell you, just as a way of um, explaining it, where some of the areas are that are expected that you need to have specialized training. For instance, if you've worked with adults in your supervision, if you've been trained clinically working with adults, but most of your clients have had depression, it's not typically expected that once you're licensed, um, uh, that you have to go out and get a whole other formalized training if you're going to work with adults who have anxiety. There's an expectation that the clinical experience you have with working with one population generalizes to another population. So it doesn't mean that every time you work with a group that's got um, uh, a different disorder, you've got to go run and get specialized training in that. But it is expected that if you are working with a condition that you are not familiar with, that you can show that you have taken steps to go familiarize yourself with that population. So, for instance, if you uh, have a PhD and you have a license and you have clinical training in terms of supervised practicum, supervised internship, um, with adults, then you are seen as qualified as being able to work with adults pretty much across the board. But if you start working with more adults who have anxiety, and maybe your experience is more in depression, then it's expected that you will go get yourself familiar with with those conditions, anxiety conditions. Now, that doesn't mean you have to go run out and get formalized, specialized training, although that certainly would be one possibility. But it means that you review the research, you take continuing education classes in anxiety disorders. If you start working with individuals with PTSD, it means that you go familiarize yourself with the research on PTSD. You get continuing education classes in PTSD. Continuing education classes are a good example of sort of being that midway between no additional training, even for conditions that you're not familiar with, and formal supervised uh, uh, training, meaning you have a supervisor. Continuing education are classes that psychologists take um, to familiarize themselves with treatments and conditions that they may not have a lot of experience with, or that they want to increase their knowledge of. Now, some states, for the reason that it improves competence, some states, in fact, many states, require continuing education. For instance, I am in Pennsylvania. Every 2 years, I have to get what is called 30 credits of continuing education. And 30 credits, one credit in our state typically equates to 1 hour. So it basically means that in 2 years, I have to have had 30 hours of training related to clinical psychology. Doesn't sound like a lot, but it can be. And it just so happens in my state, half of that is um, half of that is has to be live, and half of that has can be half of it can be live, and half of it can be in person. Except in most states, including mine, in most states, I believe California is one, they've erased the in person requirement. So right now, all 30 hours can be obtained um, through distance education. And I forget what I said before, but basically what it was is the typical law was 15 hours of sort of distance learning, either through um, reading books or reading training manuals or whatever, and then 15 could be in had to be live. Except that ever since the pandemic hit, they've changed that so it's 30 hours. It all can be distance education, but the competence aspect to it is that typically it would be with these continuing education courses where you would try to find some topic that maybe you're not as familiar with, or maybe you work a lot with that population. You really want to keep updated on what the research says about that population. Um, okay, so continuing education is often that middle ground between formal um, supervised experience that a psychologist might use to increase their competence level in different areas, um, it would continuing education would often represent the midpoint between doing nothing to advance your knowledge about a field that you work a lot in and maybe you don't have a whole lot of experience, and formal supervised training. Psychologists, where that what it comes down to is psychologists are expected to um, to get training to increase their level of competence in areas where they plan to practice. Now, some of the areas that are seen as requiring formal supervised training, if you don't already have it, is working with children. If all you've done is work with children, then you're expected to uh, get training in it before you start working with children. Another area that is seen as requiring that is clinical neuropsychology. Neuropsychology is a field that really focuses on the interaction between the brain and behavior. Clinical neuropsychologists usually do more evaluations, cognitive functioning evaluations. And so um, it is typically seen that if you do not have clinical training, formal clinical supervision in clinical neuropsychology, then you can't really do, you're really expected to not do neuropsychological evaluations unless you've gone and obtained that clinical training. Um, and that's because clinical neuropsychology is so different than clinical psychology. It requires a whole other field of expertise. You can go through, a PhD program and not get much training in neurology. But if you're going to practice in the field of clinical neuropsychology, you should have some understanding of uh, neurology and what specific areas of the brain impact on what behaviors. So, child psychology and clinical neuropsychology are two areas where you would be expected to have received formal supervised training um, if you're going to practice in those areas, um, just because they are so different from sort of the standard clinical psychology areas. Now, sometimes showing competence requires that you obtain um, a special type of certification. Specifically, what I'm thinking of as an example is school psychology. In every state, psychologists, even licensed psychologists, cannot present themselves as being school psychologists without an additional certification that they have. They usually requires additional training. So a lot of schools hire psychologists, and a lot of schools will not hire a psychologist unless that psychologist can be designated a school psychologist, and that usually requires a special certification. I want to also talk. Some of you may notice that when I sign my name, when you see my name formally, it will be Daniel Marston, PhD, but then it also will often follow with another title, which is Daniel Marston, PhD, ABPP. ABPP stands for the American Board of Professional Psychology. It is essentially the primary specialization organizations for psychologists. So, in the same way that a uh, physician might want to um, have the designation of being a cardiologist, would have to go through the specialty board for cardiologists and show that they have advanced competence in that area. Um, Psychologists can do the same for different areas of psychology. through the American Board of Professional Psychology. Now, also in the same way, it is not a requirement to have that board certification in order to practice in um, a specialty area. But it is one of the clearest ways that psychologists can show advanced competence and specialization in a certain area. The example that I might bring up here is, again, going back to a primary care physician. A primary care physician can work with any patient they want on heart related issues, blood pressure, cholesterol, atrial fibrillation, um, um, dangers of heart attack or stroke, and trying to prevent those things. Any licensed physician can work with a patient on each of those issues. It is not required that a physician have the designation of being a cardiologist before they can work on cardiac issues with patients. But it having that designation of being a cardiologist shows advanced competence and advanced understanding, so that when problems in those areas get sort of out of the realm of what um, can be addressed by just general knowledge that a physician would have, they would refer the person to a specialist. In that same way, that's what the American Board of Professional Psychology does for psychologists. My ABAP, ABPP designation, my specialty area is cognitive behavior therapy. So any psychologist can practice cognitive behavior therapy. But my ABPP designation shows that I have advanced competence in that area. I have competence beyond what just a standard psychologist would have. So that's another way that sometimes people show competence, not for an area that they aren't already familiar with, but when they want to show the opposite end, when they want to show that they have more than sort of your average psychologist's understanding of a certain area. So, whereas you can get supervised training, supervision to help you show competence about practicing in an area that you might not be familiar with otherwise, ABPP allows you to show advanced competence in an area that you may have a lot of experience with. Some of the specific areas that ABP covers and that allow you to show that advanced competence include neuropsychology. In fact, neuropsychology is um, probably the the area of competence that stands out the most from ABP. And the reason for that is many neuropsychologists um, take the stand that a person should never call themselves a neuropsychologist unless they have ABPP um, credentials in neuropsychology. Um, Another specialty area covered by the American Board of Professional Psychology is forensic psychology, meaning for psychology in the law. Not like psychology in the law as we talk about here, law as it applies to psychologists, but um, but psychology as it applies to legal issues, competence to stand trial, um, uh, you know, um, intellectual disabilities and their impact on whether the person understood what they are doing, personality issues as they relate to certain crimes. So, forensic psychology is another area where you can get advanced certification showing advanced competence. Some others include um, health psychology, rehabilitation psychology, police psychology. One of the newest ones is geropsychology, which is geriatric psychology, the psychology of older people. So um, all of those are areas where an individual might want to show advanced competence. So showing competence can be done in a number of different ways. Showing supervised training, not just classwork, but supervised training. Um, Showing evidence that you've updated yourself on the research and taken continuing education courses to advance your understanding of a particular field. Getting certified um, by, say, ABPP or maybe a similar credentialing organization as a way of showing advanced competence in an area. Um, Another step that might be used to address an area where a person may not have competence would be having contact with a knowledgeable uh, colleague. Um, that might be done having uh, consultation with a knowledgeable contact colleague might be something you do if um, if being caught in an area where you don't feel competent catches you by surprise or catches it's something you hadn't expected. Let's say, for instance, an area where sometimes I can use this for myself, an area where I sometimes will get calls from colleagues. I've mentioned here, it says in my background, I have a couple books. One of them is on autism. I have a considerable background in autism, particularly autism as it relates to children. I'm sorry, excuse me, teenagers and young adults. Periodically, I will get calls from colleagues who will want to talk with me about an experience. And what typically will happen in that case is they will get a call from someone, and the person will say, I'd like to make an appointment because I have depression. I'm an adult and I'm having problems with depression. The colleague uh, doesn't think anything of it. They have experience with depression, they have experience with adults, no problem, make an appointment. The client comes in, and as things go on, either the clinician gets the impression that the person has autism, or the person may tell them, oh, by the way, when I was in high school or when I was in middle school, I was diagnosed with autism. Didn't come up on the initial phone call because maybe the person didn't think it was relevant. People don't always think something like that is relevant when they're dealing with other issues. Um, but it may start to happen that the clinician now realizes they are dealing with someone who has autism, and maybe they have no experience with autism. They have experience with depression, but maybe not with autism. So in that case, they may not feel a need or see an ethical responsibility to refer the person elsewhere because this is an adult, this is a person who has depression. Depression was a primary problem, but they also have autism. They also are dealing with autism. So they will call me and say, hey, could you take a few minutes just to help me get a sense of what I might do with this individual? And also, uh, they may want to use that time talking with me to decide if maybe they should refer the person somewhere else. You know, are the approaches they're familiar with for treating depression going to help someone with autism? Will often be the question that they ask. But that's an example. Started off not knowing this person had autism. They hadn't called them because they have autism. They hadn't even called them for help with autism. But autism becomes a relevant issue then as the therapy intake moves forward. And so the person will call a colleague, in this case me, to ask about, hey, what do you think I should do here? So that's another area where um, the person, the clinician might um, find different. And notice how this issue of competence, it's not all one size fits all. There are different levels. Competence may come about where you feel you don't have experience with this condition or with this population, but you feel comfortable enough that if you got some reading and maybe even got some continuing education on it, you would feel comfortable. Or you might feel that, like the person who sees someone with depression who turns out to have autism, you may feel that, well, I feel like I could help this person with their depression, but um, I need to maybe check in with a colleague and get some feedback here, get some ideas about what I might be able to do, and maybe get help in making the decision about whether I can help this person. So that's on the lower end. And then on the higher end is getting formalized supervised training before you start to work with them, or maybe um, getting some sort of additional credential before you move on, like you would if you wanted to practice as a school psychologist. Um, and then on the other end, if you feel that what you want to show is not just competence, but advanced competence, that's where something like the ABPP comes in. As we talk about competence, I also want to address um, probably the most prominent ethical issue that comes up for psychologists, and that's the issue of medication. And that's because a lot of people who seek out therapy, who seek out psychological services, will be on medication, psychiatric medication, or will question whether they should be on psychiatric medication. And as psychologists, we have to be very careful about any discussion we have about medication because we are not medical doctors. And so, how much we share about medication has to be based on our level of competence. And that can change really from state to state. For a long period of time, the American Psychological Association, and I think I brought this up in an earlier class, the American Psychological Association really took the strong point that psychologists should not be giving any advice about specific medications. Um, and so saying, I think maybe you need to consider being on this medication. You should ask your physician about this medication. Or you should ask your physician if maybe they want to change from this medication to that medication, was not something that psychologists um, were encouraged to do. In fact, the APA was pretty strong about saying you shouldn't do that. Over recent years, that's become less. I mean, it's still pretty much the prominent um, position of APA, but it's changed a little. Both because one, there are some states where you can get credentialed as a psychologist to prescribe medication. So there are some states I brought up the first class, the two I know of, Louisiana, which was the first, and Hawaii, allow psychologists to prescribe certain medications, the same way dentists can prescribe certain painkillers and um, uh, anti anxiety medications. So, and, and medications for infections. So, psychologists can prescribe psychiatric medications in some states. Also, because psychologists can do that, there also become more and more um, credentials that psychologists can get, specifically on psychopharmacology. Um, so, those avenues have allowed there to be more room for psychologists to talk about medications, but it really is expected that psychologists need to be able to prove their competence in that area if they're going to talk to clients about specific medications and make recommendations about specific medications. Since that is not considered to be sort of the standard part of a psychologist's competence, since we are not medical doctors, and since psychologists are not thought to have the training to understand the side effects and how medications might interact with each other, psychologists just on a standard training level are not thought to have advanced enough knowledge of pharmacology or physiology to make specific recommendations about medications. But they can go about getting that specialized training and specialized education that can make them competent to talk about medications. Now, I will tell you that in my practice, I have found talking about medications um, easier, but that's because I'm not a strong proponent of psychiatric medications. And so I find myself more on the opposite end, which is um, talking about not needing medication, or in my opinion, that the person may not need medication. That becomes easier for me because what I can say is if someone says, "Hey, do you think I should be on an anti anxiety medication?" I will tell them, I will tell the client, I do not deal with medications, nor do I particularly like psychiatric medications, although I do realize some people are helped by them. So, what I will say is, I cannot give you any suggestions about that other than say that if you want to, you would need to talk to your primary care physician or talk to your find a psychiatrist who's willing to work with you. So that kind of takes me out of that realm, which is a realm I don't really even want to be in anyway. So, um, now one last thing about medications. Just because it is not seen as an area that psychologists from their standard training have expertise in, that doesn't mean the psychologists don't have an ethical obligation to know what medications their patients are on. So, um, very often it is seen as important that if your client is seeing a psychiatrist, that you find out from the client what the psychiatrist is doing. And if you feel comfortable with it, um, have the client, it is expected that you have the client sign papers that allow you to have communication with the psychiatrist. Um, now, um, that is usually I would say that the standard is if you have somebody who's seeing a psychiatrist, you should get permission from them so you can have contact with the psychiatrist, and it's expected that the psychiatrist should have uh, contact with you. Doesn't always happen, but that's typically seen as what's expected. It's interesting to keep in mind, by the way, that psychiatrists do not follow APA ethics, American Psychological Association ethics. They have their own ethical standards, which are slightly different. Um, so, but it is usually expected that you should know the medications that your client is on, even if you really have nothing to do with the medication other than being familiar um, with it. In part because if you start to notice a drastic change in how your client is acting or feeling, one avenue you may want to pursue with them is whether there has been any change in terms of them taking the medication or changing the medication. What I want to do now is move into the next ethical standard, and maybe what uh, I know we're getting towards the end here, and I want to make sure that I leave enough time for talking about the next ethical standard. And what we might need to do is during the class then go to some of the more specific subsections of the ethical standard having to do with competence. But the next standard is human relations. And it's interesting that this area has to do with basically how we treat people. Um, we're dealing with clients, but this is sort of the more general um, uh, aspect of how we treat human beings, our clients, but other people as well. Okay. I'm sorry, I stopped there because I wanted to pull up something. Okay. Human really, this is how we treat human beings. And you can see throughout there that discrimination, harassment, um, uh, sexism, racism, all the different types of discrimination that is out there is all addressed in these ethical standards and how psychologists basically do all they can to not only avoid those things but fight them and keep them from impacting society as much as possible. And we can talk about that later. However, I wanted to make sure that in this section of the lecture, I brought up the one change in the ethical standards that is not reflected in this book. This book, as you know, was written in 2008. There really hasn't been major changes to the ethical principles except for one. And it reflects by far the most drastic issue to come up in the American Psychological Association for at least as long as I've been a psychologist and possibly beforehand. And that has to do with the issue of torture. And in fact, you will see that ethical standard 3.04 is avoiding harm. And what happened was in 2017, so about 3 years ago, that ethical standard was changed. What you have there, what you have in the book on page 63, 3.04, is now 3.04a. 3.04b reads as follows: psychologists do not participate in, facilitate, assist, or otherwise engage in torture, defined as any act by which severe pain or suffering, whether physical or mental, is intentionally inflicted on a person or in any other cruel, inhuman, or degrading behavior that violates 3.04. So, um, again, let me just read that real quick. Psychologists do not participate in, facilitate, assist, or otherwise engage in torture defined as any act by which severe pain or suffering, whether physical or mental, is intentionally inflicted on a person or in any other cruel, inhuman, or degrading behavior that violates section 3.04. Now, that was adopted formally in 2017, but the amendment was brought up in 2010. It was debated a long time, but it was fascinating to watch. I mean, this issue impacted the American Psychological Association, was a major issue at every convention I was at or heard about. It impacted the the office, the elections for officers of APA, the president for years. Um, if you compare the membership of APA now compared to the APA membership 15 years ago, it's much less. A lot of members left because of this. And here's what it was. It's not that the other aspects of human relationship that would fall under standard 3 didn't impact psychology. Psychologists were a major part of fighting racism, sexism, sexual harassment, um, uh, ageism, the treatment of, uh, the unfair treatment of people as they got older, all of those, workplace discrimination, all those, psychologists were a major part in fighting those and trying to change them and continue to be involved a lot um, in all of those issues, all discrimination issues. But torture took on a specifically strong um, place in psychologists because you may remember years ago uh, during the war on terror, the fighting in Afghanistan, there was a lot of information that came out about torture and how prisoners were being tortured, captured soldiers on the other side were being tortured. Waterboarding became a major uh, uh, phrase in all of that discussion. And what really impacted on psychologists, particular, is that it became clear as this was coming out that psychologists were the ones who were developing those procedures. Psychologists did not invent sexual discrimination. Psychologists did not invent racism. By all accounts, psychologists did invent waterboarding. Waterboarding was developed by psychologists. Um, Many torture methods that were used by the American military that came out were developed by American psychologists. Um, so that's why it took on such a major impact in um, in the American Psychological Association, um, and what eventually led to this ethical standard, because um, it was coming out that not only were these things being done that many psychologists um, disagreed strongly with, but it was psychologists who were doing that. People who developed waterboarding, people who developed torture methods were members of the American Psychological Association. Um, by the way, many of them continue to be, because it wasn't like an all across the board type thing. There was a lot of criticism about coming up with these things, but then there was a lot of pushback also from organizations who specifically represented military psychologists. Um, um, there is, and I just looked this up, there is a division of American Psychological Association. This American Psychological Association is made up of 60 plus divisions of different areas. Division 19 is the division of military psychology. So it wasn't like the pushback was all in one direction, or the push was all in one direction. There was also pushback from military psychologists who said, wait a minute, these are legitimate ways of obtaining information um, from prisoners that can be used to save lives. You probably heard all the arguments that were put out there both against torture and for um, torture, which the military psychologists were not calling torture, we're calling information gathering, coercion techniques, all those sorts of things. But so there was a big push against it from many divisions, and then push back from divisions like Division 19, the Division of Military Psychology. So for years, there was a lot, it had a major impact on the American Psychological Association. And it is an important part, continues to be an important part of psychologist history, because, like I said, whereas these other um, major aspects of society that have created a lot of negative impact, had a lot of negative influence on society and need to be addressed, were ones that psychologists were addressing. Torture really had a major impact because it was one uh, that was seen not only as one that psychologists were addressing, but ones that psychologists started. So uh, that's why it really had a considerable impact on the American Psychological Association. So we will talk later about the different sections of the ethical standard having to do with human relations, about how psychologists treat not just clients, but human beings in general, and how they act towards human beings as a psychologist, as a professional. Uh, but I really wanted to take a good bit of time to talk about this ethical standard having to do with torture. One, because it's the one that isn't in your book. All the rest of them have stayed the same, but that's the one that was added in 2017. You'll notice too, from what I said, how long that debate took. Starts in 2010, gets formally adopted by the American Psychological Association in 2017. But I really wanted to bring up because, again, like I said, there has been probably no issue that has impacted the American Psychological Association directly as much as that ethical issue, and continues to be one that's debated. Okay, we'll talk about the rest of the principles when we meet on Thursday, and I have submitted the exam, so that is in there. So, like I said, you can have until the end of the day, Friday, to turn it in, but just keep in mind the exam is there. I look forward to seeing everybody on Friday morning. See you then. And I may have said Thursday before. I apologize. That was a mistake because I have another class that's on Thursday. But our class will meet Friday morning. I will see you then.